Excellent presentations from all three high-volume surgeons from three high-volume institutes. I know all of them personally, Partha and Mahesh and Rajesh. I thanks Dr. Vijay also to include the GE junction topic in the presentation, because it's easy to treat the stomach the middle 1/3 or upper 1/3. It's easy to treat the stomach distal, but that the controversial topic where the GE junction, say words, confusion, clarity. I think excellent presentation from all three speakers. And any questions in the audience, or probably Subbu sir here, Partha has quoted his paper about transhiatal thing. So I think practical approach Subbu sir can tell, or any other questions in the audience, and I'll ask one question later.
No, I think to prove a difference in these surgical studies is always difficult, is it not? It becomes multifactorial. Institutions, surgeons, groups of surgeons, and things like that. And extent of lymphadenectomy is when it is a major difference, a 3-field lymphadenectomy itself could not prove superior. So how could something in between prove a difference? So that would not happen, but we changed. See, I've practiced transhiatal esophagectomy for 20 odd years. And into minimal access also. But we changed that about 7-8 years back, because over 12 years we had 6 diaphragmatic hernias, the hiatal hernias, and all of them were transhiatal dissection done, and especially when you try to reach the carina from below. So what happens there, the phrenoesophageal ligament is cut, and then 2 instruments go in to give you space, and you keep on dissecting upwards, the diaphragm gets torn, and your vision is at the end of the scope, at the end of your energy tool. So when you come back, many times you don't know that you have either widened the hiatus significantly, or you would have actually torn the fibers. So I thought, in a high volume center where lots of trainees and lots of layers of consultants are there, we'll stop this and then do the thoracic component as the second part. We do everything from the abdomen, not open the hiatus, and do the infrazygous part only in adenocarcinomas. It does 2 things. One thing is you are not tampering with the hiatus at all. Second thing is it gives a wonderful opportunity for trainees to learn thoracoscopic part of the esophagectomy, because it's a normal esophagus. So the training levels have gone up, the diaphragmatic hernia levels have completely come down. So that is purely the reason, not discussing about cure rates and all, I don't know. But we do, for adenocarcinoma, infrazygous lymphadenectomy is done because we get into thorax.
Another difference we have noticed is that because transthoracic, we identify the thoracic duct as well as the tracheobronchial tree very clearly. There should not be any incidence of injury to either tracheobronchus or the thoracic duct, because it is under vision. So that's another advantage of routinely following the transthoracic approach to esophagectomy. One, Subbu has already said, as part of training also, even if you are not a believer of doing transthoracic for GE junction tumors, for thoracic esophageal tumors, you believe in transthoracic approach. For training purposes, lot of the young surgeons get used to doing the thoracic component of a normal esophagus, which will be beneficial when they really have to do for a thoracic esophageal carcinoma.